Good morning and welcome to Grand Rounds. So this is a real distinct pleasure for me to have Michael Gold here this morning. He was coming through the West Coast, and so we were fortunate enough to grab him for Grand Rounds this morning. So Michael's Professor of Medicine at the Medical College of South Carolina and holds the Michael E. Assey Professor of Medicine Chair. And he's really truly been a leader and a visionary in the field of electrophysiology. He got a PhD in physiology from the University of Virginia and then did a postdoc fellowship at Colorado, where he also completed medical school there. And then his residency and cardiology fellowships were at the MGH. He began his academic career at the University of Maryland, where he was director of EP and the EP fellowship program there. And then in 2002 was recruited to USC, where he was director, division of cardiology. And now is Associate Dean of the Interdisciplinary Clinical Program. He's also past president of the Heart Rhythm Society. Michael's participated, I think, in most of the important clinical trials in EP that I can think of going way back, both NIH trials as well as industry-sponsored trials. He's had a particular focus on devices and novel devices and was involved in CRT really at its inception and has pushed that field significantly forward. He's been a mentor, a colleague, and a friend to, I think, almost everybody in EP, and I know for me he's been an important mentor for me and friend in my career also. So today Michael's going to talk to us about CRT, what's the background for it, and what lies in the future for CRT. Michael, thank you.
Well, thanks, Gina. Those very kind comments. Hopefully a little bit of it is actually true. What I'm going to do is hopefully give everyone a perspective. I like when I'm at universities because we have a lot of young doctors and aspiring doctors, as well as people who've been there, to give a little bit of history sprinkled in with, I think, where we are and where we're going, which is the reason for my talk. And people frequently don't realize that pacing for heart failure is a relatively new field in the big scheme of things. Pacers were developed to treat heart block 50 plus years ago, and it's only more recent that someone thought you could actually pace for hemodynamic purposes. And the first study, and the study that really caught everybody's eyes, was a study out of Austria by a cardiologist by the name of Margaret Hochleitner, who put standard pacemakers into patients, and the only thing she did differently was to pace with a short AV delay. Rather than a normal 150 millisecond AV delay, was 100 milliseconds. And this was in an era where there were no LVADs, nothing else, and she had a bunch of really sick patients sitting in the CCU in Vienna with Swan-Ganz catheters on, waiting for heart transplants, and she put in these pacemakers for unclear reasons, and then reported these unbelievable results, which turned out to be actually unbelievable. But heart failure was getting better, ejection fraction was getting better. Stories of these patients who've been in the CCU for months would rip out their swans, get on their bicycles, listen to their Walkman, and everything was getting good again. And it got people excited. And I went to the University of Maryland at that time, sort of in my first job, just when this came through. And again, just a bit of trivia, the people who invented the defibrillator, Murawski and Mower, who are very famous for that, also have the original patent on CRT. And they came to me because I was young enough to sort of say, you got to start thinking about this sort of stuff. So the first thing we did was to try to reproduce their findings, and we couldn't. Hemodynamically, we couldn't find anything. It was nice that in that era you could do a study of 6-7 patients and publish it in JACC, because there was no data for this. So we couldn't find anything that we could find, and subsequently people started doing studies showing that pacing the right ventricle, which is what Hochleitner did, in fact was bad for patients. I was invited 4 times to Europe to either debate or be in conferences with Dr. Hochleitner, and she never showed up at any of these. And in fact, to this day, I have never met her. I know no one, and if anyone in this audience knows her, please let me know. I know no one who has ever met this person, yet I'm told she actually does exist, and she is the reason why this field got started and got going. But since right ventricular pacing wasn't of interest, we started looking at biventricular pacing. And the first model was a easy model to do. We had a very great cardiac surgeon who I started with who wanted to do electrophysiology research. So at the time of bypass surgery, when we put epicardial leads on patients routinely, put one lead on the right ventricle, one lead on the left ventricle, and again, we did this brief hemodynamic study which showed that biventricular pacing, we didn't have the term cardiac resynchronization therapy at the time, would actually improve hemodynamic function. And for the electrophysiologists in the room, we actually could do mapping studies before we had fancy maps, and these were the days where you do them in the OR and you put these socks over the heart and could map all these points in the heart. And what we could show was that when we paced the right ventricle, the earliest breakthrough in red was along the septum, territory of the LAD, which you'd expect as it's crossing the septum. When we paced the LV, it's where we had the electrode and these polar maps near the apex. And when we paced biventricular, we got both spots being activated and a more homogeneous activation of the ventricles we mentioned, which again, we didn't understand the significance of it. I started promoting this concept of biventricular pacing that we had, quote, discovered, and a very well-known cardiac hemodynamic heart failure doctor, Dan Burkhoff in New York, when I was speaking up there, said, you know, you shouldn't be, Michael, you shouldn't be talking about this like you guys came up with it, you know, because in the 1990s, because in the 1980s, we did this in dogs, and we showed this, so I felt guilty, and I thought I should always sort of have Dan's recognition for that. And then I was actually out here on the West Coast talking about this and showing what Dan did. And Frank Tyers, who's a surgeon up in Vancouver, then came to me and said, you know, you cardiologists are all the same, you think you discover everything. But in fact, us surgeons knew about this back in the 1970s, and we did it in cheap. And again, I apologize to Frank that my subscription to the Journal of Surgical Research had expired. I hadn't seen his paper. And I was started getting tired of being embarrassed about everyone having done all this stuff or knowing about this stuff. So we actually went back and we found that Carl Wiggers in 1925 actually showed the left ventricle is the best place to pace. And I've yet to see anyone scoop Carl Wiggers at this point. But like many things, people discover it and don't know how to do it or what to apply about it, you know, and it gets discovered over and over again, sometimes intentionally, sometimes unintentionally. We tried to actually do a study, again, with Drew Foster, who sadly died prematurely, so I couldn't do much research with him, who was my surgeon I work with, and we enrolled 4 patients in this study of truly heart failure patients. This was the day before we had any coronary sinus leads or anything else. We didn't have pacemakers, so it was like Rube Goldberg. We were jerry-rigging leads to communicate with each other and hook them up to standard pacemakers in the operating room and putting leads by thoracotomy, and basically it didn't work. All patients died. Fortunately, none of them from what we had done. No one seemed to be getting better. And we figured at that point we needed to stop. It wasn't fair to continue this when we didn't know what was going on. At the same time we were doing it, there was another group in Utrecht in the Netherlands who was also doing this, and they had about 6 patients, and they had like 1 or 2 sort of spectacular successes, and everyone else was like us. Patricia Bacher, she was the cardiac surgeon at the time, and we sort of scratched our heads, and again, what seems so obvious now was naive, and in retrospect, the 2 patients who really responded had left bundle branch block. We were just putting these into bad heart failure patients and didn't think about it. Well, once people started to realize why QRSs were important, there's a whole series of studies, and for the sake of time, I'm not going to go through the Miracles Companions, severe heart failure, mild heart failure, but the breadth of data in support of CRT, I would argue, is as strong as anything we do in the world of arrhythmias. I mean, it's really impressive. And there have been over 12,000 patients who've now been in randomized, prospective, multi-center, randomized controlled trials of CRT for systolic heart failure, quality of life, Functional status, exercise capacity is improved. Strong evidence for changes in LV structure. Reverse remodeling, which I'll point to in just a minute, I think is probably one of the most important findings we get, and really one of the great predictors of our findings. Reductions in mitral regurgitation, and reductions in heart failure and all-cause morbidity and mortality. And I really would challenge anyone to find any therapy we do in cardiology that meets all of these sort of criteria. It really is a wonderful therapy. But the bugaboo that gets everyone is this idea of non-responders. And I don't think you can publish a paper in the world of CRT and not say that there's a 30% non-responder rate. It's in every paper in the field. And it's been stable for decades. But we don't even know how to define non-responder, and you can come up with many definitions and come up with very different rates, but I think more importantly is what is a non-responder. This is just one, and we published a different paper with even more data, but basically if we use soft functional endpoints such as change in New York Heart Association class or quality of life, non-responder rates are probably around 25%. If we use remodeling endpoints, changes in left ventricular size or ejection fraction, non-responder rates may be 45%. And again, there's a zero consensus about what you use. You can define anything you want. And papers have multiple different definitions. Again, this is a study that we did based on the reverse study, just showing the value of CRT and particularly the endpoint of reverse remodeling. If we use probably the most commonly defined endpoint, which is a 15% reduction in left ventricular end systolic volume, you can see that it's a wonderful predictor of survival. And in this study, the total mortality, all-cause mortality, if you are a reverse remodeler, is 1.4% per year. This is a group of patients with a mean age of 68 going in, a mean ejection fraction of 28% going in, and we're talking about an all-cause mortality in that group of 1.4% per year, which is not a whole lot different than what the general population would be for that group of patients. So it really is a very strong predictor, and fortunately, finally, the FDA has bought into the idea that we can use this as an endpoint, which is really driving the field forward, because you don't have to do these large mortality studies anymore. But I think a very important point is trying to define what is a responder. And just to sort of talk about it here for a minute, you know, patients' heart failure is getting worse, and hopefully I won't offend the heart failure physicians here, but at some point they get worse and we put in a CRT, because they're class 2 now or class 3 in the past. And some of them get completely better, and we call them super responders, and we pat each other on the backs and we feel great about it. Other patients get better, may not completely normalize, and we call them responders, and no one argues about that. The question is, the patient who stabilizes, what do we define them? They're now called non-responders, but we know the natural history of heart failure is very well described, and if we do nothing to those patients, they're just going to continue to deteriorate. I mean, heart failure is a lethal disease, and that's why we put in LVADs and do heart transplants and do other things to these patients. And those are truly non-responders if they just followed their natural history. What do we call the non-progressors? Is that a bad thing if someone with class 2 heart failure stays that way for 10 years with CRT? I'm not sure that that's a bad thing, and certainly different than probably the general heart failure population. And then the one thing we do have to remember is that we can make people worse with CRT. It's not a fail-safe therapy, so we do have negative responders. But with that in mind, how do we sort of maximize our response rate? How do we make CRT as good as we can make it? I think there's sort of three major sort of areas to focus on. One is the appropriate patient. One is where we place the leads and the programming of the device. And then the third, which is pretty much neglected by electrophysiology, is the follow-up management of those patients. So just talking about the appropriate patient, the easiest thing is to cherry pick your patients if you want a good response rate. So we know that women respond better than men, non-ischemics respond better than ischemics, wider QRS responds better, left bundle responds better. And we know that clinical predictors of poor response, if you're inotropic dependent, The horse is probably out of the barn. If you have a very scarred ventricle, there's not much to recruit by pacing. And height, which I'll talk about in a minute, which is sort of fun, new thing we've sort of stumbled upon. But these factors are interrelated. So if you have a non-ischemic woman with a wide left bundle branch block, I'm not going to tell her she has a 30% non-response rate. If she doesn't respond to CRT, I'm probably doing something wrong with her. Whereas if I have a man, with 4 previous MIs and has an IVCD with a QRS of 130 milliseconds, I'm going to tell him the chance of me helping him with CRT is pretty low. So we can a priori decide much of this. The study that really got everyone going is analysis from the Made It CRT study, which said that only left bundle branch block patients respond. Now, I can criticize the study because I'm actually an author on this study. But based on this, the guidelines have changed, and based on this, many people, and I would think that some people in this room will tell you should only implant CRT in left bundle branch block. But if we look at just to talk about the interrelationships of all these factors, if we look at this, this is from this exact group of patients from this study, which didn't get mentioned much. If we look at the QRS duration in the left bundle branch block, it's much larger than in the non-left bundle branch block. The percentage of men is significantly lower. The percentage of ischemic heart disease is significantly lower in left bundle branch block. So everything, it's all those factors together rather than just left bundle branch block. And it was never corrected for. There's no multivariate analysis in this paper. It somehow got published in Circulation because it had the title Made It CRT attached to it. And so we started to question that, and some of my favorite cynics who happen to be in Europe, John Cleland is one of them, who's a very smart, thoughtful guy. We did this individual patient meta-analysis. As opposed to usual meta-analysis, this is where you know all the patient data, so you can actually pool the patients together, and you end up with a study of thousands of patients rather than hundreds of patients. And when you do the individual patient meta-analysis, the number one predictor of response is QRS duration. And in fact, sex, QRS, morphology, left bundle versus right bundle, and etiology of heart failure falls out. None of them were predictors, independent predictors of response. It was all QRS duration in this analysis that we did. And in fact, the cutoff, if we look there, is around 125 milliseconds or so, where you start to do harm from patients, which, interesting, is very close to where the clinical studies and the guidelines started to look at it. So I think it really makes us start to think a little more about just saying, closing our eyes after we look at whether it's a left bundle or a non-left bundle. And clearly, QRS is important. This, I think, ill-fated study called ECHO-CRT took patients all with narrow QRSs, less than 130 milliseconds, but they had a mechanical desynchrony, and they were randomized to CRT or no CRT, and CRT increased mortality in this group. So it's actually contraindicated, and as I pointed out, you can hurt people with CRT. If you have a normal conduction through your left ventricle, as evidenced by a narrow QRS, you are making them worse by artificially pacing 2 sites in the ventricle. A second individual patient analysis more recently got done, again from Martin Cowie and group, which again came to very similar types of conclusions. They found that younger patients, women, and QRS duration were the predictors of response. But once again, left bundle branch block was not a predictor of response to CRT. It's just the company that left bundle branch block keeps with. So again, I think we probably need to be a little more open in terms of deciding on things. More recently, we have this study we published, which I think is very intriguing, at least provocative, an analysis I did with Cecilia Linda in Stockholm, looking at, again, the reverse study, but a large group of patients, and this was the data on height. And it turns out that height was a negative predictor. The taller you are, the worse you do with CRT. The shorter you are, the better you do, and it interacts with QRS duration again. And this is at least one potential explanation. Why do women do better? Women on average are shorter than men. But if you just look at men, short men do better than tall men. If you just look at women, short women do better than tall women. And the problem with this is there's not a lot of great explanations, biologic explanations for QRS duration and so on and so forth, and height. Women have shorter QRS durations in general than men, which is why they may respond better, because the whole curve is shifted a little bit towards shorter durations. But again, it's a lot of complexity in terms of how we analyze things, certainly from just a baseline QRS. Well, once we've sort of decided what we think may be the appropriate patient, I think ventricular lead position, which is something I've spent a lot of time working on in optimal programming, is sort of the next thing that we need to be focused on. And for many, many years, the leads were placed always on the lateral wall of the left ventricle. And again, if we go back, this was based on some early studies out of Germany, some acute hemodynamic studies of 10 or 12 patients saying you should only pace the lateral wall. And people started then to look back at how good is that, even though it was a dogma to the point that people were saying if you can't place a lead on the lateral wall, you should take the patient to the operating room and have the surgeons do it, and so on and so forth. If you start to look at the companion study, you see that if you look at the data, again, retrospectively, but anterior, lateral, posterior, for no matter what the endpoint is, it doesn't make a whole lot of difference. Where you were placing the lead didn't seem to really make a whole lot of difference. And subsequently, the Made It CRT study, Jack Singh did an analysis. Again, anterior, posterior, lateral didn't make a difference, but placing in the apex was a bad place to pace the heart. And so people started to get the idea that, well, just pace anywhere, but pace away from the apex of the left ventricle is where you want to place a lead, anatomically guided. And we looked at the reverse study and could confirm that, in fact, the apex was a bad place to pace the heart, although the lateral position did appear to be a little bit better. But it was clear that anatomy may not be the great predictor that we thought it was of where to place the heart, where to place the lead. So I think, importantly, people started to think physiologically, which is always what I like to focus on when we can. And some of the early work was on scar, using MRI, which was much less common 10, 15 years ago. But patients with a lot of scar don't respond to CRT. And the quantification, the amount of scar, correlates well with the response to CRT or the lack of response to CRT. And after looking at scar, people then started to look at dysynchrony, mechanical dysynchrony, and showing that if you place the lead in an area of late contraction of the heart, the idea there that that late place, by pacing there, becomes an early contraction, and you'd be resynchronizing. And they had data that if you're in a discordant lead position, so not in a late activation area, you didn't do as well as if you had in a concordant area, in an early activation area. And based on that, two actually randomized studies were performed, one out of Pittsburgh, one out of the UK, randomized controlled studies, relatively small, about 200 patients each, using speckle tracking echo to find the late activation site, and then to randomize patients to either put it anatomically where we think the magic spot is, or to put it at areas of late activation. And both studies showed small but significant, statistically significant improvements in terms of remodeling, in terms of heart failure hospitalizations, if they were targeted. And here's heart failure hospitalizations. So very encouraging results. The problem or the challenges with that is that speckle tracking is not easy to do. I'm a really bad echocardiographer, so I can't even see it or interpret it. And trying to correlate what you see on an echo image with where you're going to be in a fluoroscopic image in the heart is not trivial sometimes. So we started to work on simpler models and looking at electrical models. So can we figure out an electrical measure, since this is an electrical therapy? And the first work we did was a measure we called the QLV. which is the time from the beginning of the QRS complex, so that's the beginning when the ventricle starts to be activated, to the local left ventricular activation where electrode is. And a similar concept, if you pace at a place that has a long QLV, such as on the right-hand side here, you're going to get greater electrical resynchronization of the ventricle than if you pace at a place with a relatively short QLV, like shown in the left-hand panel for you there. And we did a series of studies looking at it, but one of the interesting ones is that we looked at this very large database that we had to try to correlate anatomy with electrical measures, because people said, well, you're just looking at, that's just a surrogate of anatomy. But if we look at what we think to be the magic spot to place a lead, which everyone would tell you is the magic spot, is the mid-posterolateral segment. If we take now 230 patients who had leads, this is a multi-center, it's not our center, and all core lab adjudicated, the QLV is between 15 and 195 milliseconds in what's considered the best spot. It's telling you nothing by anatomy of what your electrical timing is within the heart. So clearly, there's a disconnect between anatomy and physiology, not surprising with hearts that are been damaged to that part. So we did a hemodynamic study where we put Millar catheters in the left ventricle and measured invasively the PDT and could show that there was a nice correlation. The more we're electrically resynchronizing, the longer the QLV, the greater the hemodynamic response. We then did probably the first large-scale study of this concept, where we had a group of about 800 patients, again from a multi-center trial, and looked at the QLV with remodeling, left ventricular end systolic volume or ejection fraction or quality of life, and we saw a nice correlation. The longer the QLV, the greater the remodeling, my favorite endpoint, and whatever remodeling endpoint we wanted, things looked very good. So very encouraging sort of results. We then looked again at mitral regurgitation, which we think is an important marker. Patients with reductions in mitral regurgitation do better with CRT. And patients with long QLV, divided at the median here, have a greater reduction in mitral regurgitation. So a lot of good things happen if we're pacing at areas of late electrical activation. I think one of the most interesting and important findings from my perspective is this sort of forest plot in which we took this very large database of QLV and now looked at all the clinical predictors I talked about of CRT response. Left bundle versus non-left bundle, wide QRS versus not as wide QRS, ischemic versus non-ischemic, males versus female, the four things that we sort of focus on in the world of making clinical decisions a priority. And you can see for every one of them, it doesn't make a difference. If your QLV is long, you're going to respond, whether you're a left bundle or non-left bundle, whether you're a QRS greater than 150 or less than 150, whether you're a man or a woman. The difference is it's harder to find a long QLV in a right bundle than a left bundle or in a man versus a woman. So the proportions are just typically where those spots are where you're going to find those longer QLVs. So we moved on to looking at, rather than left ventricular delay, which was a QLV, to look at interventricular delay, which is RV to LV times. And part of that was it brings the right ventricle into the picture, which I think is probably important. And the other thing was just pragmatically, devices can automatically measure the right ventricular to left ventricular time, whereas QLV you actually have to do by yourself. So it was a more practical measure. And to our delight, when we look at the data, it's as strong, if not stronger. So the curves look very, very nice in terms of the relationship between RV-LV and response. RV-LV times are shorter than QLV because the RV gets activated later than the beginning of the QRS, so it just tends to be a somewhat shorter number. But you see a very nice relationship once again. And in a completely different database, anyone I've shown you before, the PEGASUS trial, which was a negative study, we thought was sort of a wasted trial, but we actually had all these data on 1,300 patients. And we can show, once again, that electrical delay here, the RV-LV time, is a good predictor of heart failure hospitalizations in this group of patients. So again, independent, large, multi-center trials. People have started to look at other ways of pacing the heart. Endocardial pacing makes a lot of sense. Again, going back in time to Bob Meyerberg, some of his earliest work many years ago now, 40 years ago, showing for endocardial pacing recruits the Purkinje network. You get a better activation, better hemodynamic response. Some interesting work out of Johns Hopkins in which they put in a CRT lead in a standard way, and then they put a left ventricular lead endocardially in and sort of put it right next to it, sort of kissing where the epicardial lead through the coronary sinus was, and could show consistently it was better to pace endocardially at the same exact spot, except on the other side of the myocardium. And so people started to, they did a trial called the All-Sync study in patients who were non-responders, where they couldn't get into the coronary sinus, where they went transeptal through into the left atrium and then across the mitral valve into the left ventricle, something that I had sort of was worried about many years ago in an editorial because of the risk of embolic events, and they got a nice response. Patients did respond even though they hadn't been responding before, but the problem with this, which again is what we had seen before, is that 5 out of the 25 patients, or 20% of them, had either a stroke or a TIA despite all being anticoagulated. So I think the risk still in my mind is prohibitive to think about sticking leads and leaving them on the left side of the heart. But to try to solve that, the SOLVE study is undergoing. This is a study which is kind of acute, but probably long-term impractical system, where a little pellet about the size of a rice kernel is placed in the left ventricle, and it's an ultrasound transducer, so that ultrasound waves are sent from this pulse generator that's synchronized to the QRS, and the ultrasound is transduced to electrical signals, and it paces the heart. So you can get left ventricular pacing for that. We actually are in the process of doing this clinical trial right now. It's very hard to get patients, so it's moving along very slowly, but certainly an interesting approach. And I think it's part of what I think is going to be the future of devices in general, that we're probably going to get leads out of the heart altogether. So everything's going to be leadless and subcutaneous, and that'll probably be our systems of the future. So I just want to move on now and talk a little bit about how we optimize or how we program devices, which again was all the rage for many years and fell out of favor for many years, and I think is hopefully going to get resurrected a little bit. And the standard way that we were doing optimization was with echo, and typically the most common way was looking at mitral inflow. So you look at the mitral inflow pattern, and if the programmed AV delay was too short, the ENAs get truncated. If it's too long, the ENAs get fused, and if it was right, the A wave was bigger than the E wave, and you would play with PR intervals till you sort of saw this right thing, AV delays, and that's how you'd program your device. And fortunately, again, because I don't know how to do echo very well, one of my other favorite cynics in the world, Darrell Francis, who's in London, did this remarkable study. Remarkable because I can't believe he actually did it. So what Darrell did, and he published this study, was that he took in the United Kingdom what are the 30 most experienced echocardiographers who do CRT stuff. And he gave them a group of tracings like this of 6 different AV delays, real AV delays, and asked them, what is the optimal AV delay for this patient, A, B, C, D, E, or F? So they got these 20 traces. And we can see for patient 1 here, there clearly was a favorite in D, but it's not quite as clean as you'd expect. So not everyone picks the same one, and there's a fair bit of variability. But The devious side of Darrell is that there weren't 20 subjects. There actually were only 10 subjects, and he put each set of tracings, he duplicated them in there. So everyone was reading the same tracing twice at the same setting. So this is the same experts doing this. So what happened? So for this example, we're going to pretend that patient 1 and patient 11 was the example. So this is where you have the same exact patient. So how do they choose? What do they choose? This is individual experts. So for those who remember your psychiatry rotation, I think this is a Rorschach test. That's really remarkable. So what's even more remarkable after they did that is this is what he has concluded in his manuscript. The operators disagree with each other. The operators disagree with themselves. They disagree just as much with themselves as they did with others. And its final conclusion was that this was not a failure of the method, but they did not know what they did not know. So I think this was one of probably the last straws for routine echo optimization using this sort of technique. So industry got involved, and all the companies started to develop their own very reproducible methods of using electrical measurements in their device. And each company had their proprietary way. The Freedom trial was by St. Jude, which looked at trying to reproduce filling of the left ventricle. And they showed that 67.52% of patients improved when you use this algorithm compared to 67.51% of patients. So if you do the math, you need to enroll 10,000 patients to have one more patient improve. So not a very good therapy. The one that I was excited with and I had worked on was looking at electrical timing to fuse with conduction down the right bundle. And the hemodynamic data looked unbelievably good. We were really excited about it. So we did a study called the SMART AV study. And again, disappointing. The remodeling was a little bit better with the SMART delay, the proprietary term of it at the time, study, but it wasn't what we had hoped it would be. It wasn't nearly, it was rather disappointing. A third study called Adaptive CRT by a third company, again, a total bust. So the question was, are we just missing the boat? Are we wasting our time to do any AV optimization? And I think one of the things that we've more recently discovered is that you can't always turn lemons into lemonade. A non-responder may be a non-responder because of the narrow QRS, the lead's in a bad position. You're not going to salvage someone who's not going to respond simply by tweaking their AV delays. But can you optimize pacing to make a responder a better responder? And we've started to find some data in a couple different areas that sort of support that. So this is the adapt response data showing that if you take patients and where they focus on was left bundle branch block and normal PR intervals, that group of patients who have high response rates, they respond even better and significantly improved retrospectively when looking at this algorithm. What we looked at was, again, my favorite, the QLV, or in this case, the RVLV. And what we found, again, is that if we now look at the interaction between the two, as the RVLV time gets longer from left to right here, all of a sudden, AV optimization becomes good, shown in black here. So again, if you're not resynchronizing or not going to respond, tweaking the AV delays aren't going to help you. But if you are, you can get an even better response. And what I'm very pleased about is we're actually doing 2 prospective randomized studies to confirm this. So going on, the ADAPT response study is being done, and I'm helping to lead this study called SMART CRT, in which we're taking patients who have a significantly prolonged RVLV time, and we're going to truly randomize them to use the algorithm or just use nominal settings, hopefully to show, we've been burned before, but hopefully to show that there is a role for AV optimization, but you have to have a patient who's going to respond, either by patient selection or lead position, where they're going to respond. So I think the importance of CRT response is not just choosing our patients, but we need to have the right patient. We also have to have the right pacing site, and probably have to program the device correctly. But you got to put it all together if we're going to have a response in this group of patients. And then if we just finish up sort of briefly with the follow-up management, again, which I mentioned, many of us in electrophysiology, I try not to be as much of this maybe as some of my colleagues, but you put in a device, you feel good, you check the wound the next morning, and you say goodbye to them and send them back to their cardiologist or back to whoever. And we lose track of that. And the question is, how do we measure non-response? Validated endpoints are rarely used in clinical practice. We don't do routine 6-minute hall walks and a bunch of other things in these group of patients. And it's classified by subjective assessment. The patient comes back in a couple of months and you say, do you feel better or do you not feel better? And that's often how we're classifying our non-responders sort of clinically as we manage them. And a patient may not be feeling better because they have COPD and it's not their heart failure, which is causing their shortness of breath. They may be feeling better completely because of the placebo effect, which is very potent with this therapy. So it really needs to be supplemented with something functional or structural. I tend to, again, like the echo, that if they're remodeling, reverse remodeling, that's a very good sign. Others have used, and it's very reasonable to use walk tests or other things to see if they're getting better. And it's important when we see non-responders or where patients don't appear to be better to really evaluate them and not just sort of, we did what we could do and goodbye. One of the biggest reasons is atrial fibrillation. Patients go into atrial fibrillation and they're no longer pacing, so it's sort of a double whammy. It's the problems of atrial fibrillation on them and the loss of CRT. It can be due to rate control not being good or just not pacing coordinated. So a number of things we can do for that. It can be volume status. The heart gets stronger, ejection fraction goes up, patients are autodiuresing, but it's not unusual that patients will become volume depleted after you put in CRT. So actually backing off of diuretics can be something that makes patients feel a whole lot better when you put that in. Do they have ischemia? Now that they're more active, are you starting to see cardiac ischemia? Again, is the depression, COPD, arthritis, anemia, is there something completely unrelated that we're not looking at? And we've gotten better at being able to assess at least the electrical aspects of things. There's this reproducible data, which is, again, I think provocative, of big data sets of remote monitoring. All our patients now are on these monitors at home, and we can monitor them. And patients who are on remote monitoring live longer than those who are not on remote monitoring. We assume that most of that is because we pick up things like lead malfunctions and AFib and all those things much sooner. The more cynical view is that maybe this has to do with just that they're more compliant patients and more engaged patients who want to do it. But clearly, it's good to be on remote monitoring. And this is, again, 100,000 patients in these analyses. We know that the impact of biventricular pacing, the amount of biventricular pacing is important. This isn't something where you want to be pacing most of the time. You got to be pacing almost all of the time. So it used to be considered 85%, then it became 90%, then 95%. And again, even in these large data series, you can see that over 98% is better than less than 98%. So it really does make a difference how much you pace. And there are now data that if they're not pacing because they're having frequent ventricular ectopy, ablating their PVCs is a good thing. Something which we didn't think about doing much, but again, for patients who have a significant PVC burden and not responding, PVC ablation is something certainly to consider in this group of patients. For patients with AFib, if you can either consider whether it's an AFib ablation or most of the literature has been done on AV node ablation. Do an AV node ablation so they're now pacer dependent and you pace all the time. But most of the Europeans have been very aggressive about AV node ablation, but lots of strong data that forcing them to pace will improve the outcomes on those groups of patients. And then finally, I think one of the best outcomes for these patients comes from having a multidisciplinary clinic. when you actually have the heart failure doctors and others working together with the electrophysiologists. This is Mass General where they did it, and just showed, again, less heart failure hospitalizations. I mean, many things in heart failure have been shown by frequent visits and attention to detail works well. And you work together as a team, you get better outcomes from these patients. So, just to finish up this sort of whirlwind tour, again, hopefully my passion at CRT is one of the most important advances in the treatment of heart failure has sort of come out. Reverse remodeling is important. It's what we look at now. It's what many of our studies are targeting. Electrical desynchrony is necessary, so patients with narrow QRS are going to be harmed. Don't do it. Don't give up on non-left bundle branch block patients, particularly the longer duration non-left bundle branch block patients, because many of them have areas of electrical desynchrony where we can pace and they'll get better, which is why physiologically guided pacing, I think, is important where we place the leads, and it may be a good place where AV optimization is going to be important. And then finally, I think systematic follow-up of these patients, a multidisciplinary clinic, taking care of these patients after we implant the device, I think is important, certainly as electrophysiologists, and not just see ourselves as proceduralists. Thank you.
Questions?
I'm wondering your thoughts on multi-point pacing. Do you think that's going to pan out?
I don't know. Again, the data are pretty weak. They now have devices, for those not familiar with it, where you could pace multiple points along these leads because we have 4 electrodes on the leads. What we know for certain is that it markedly depletes the battery. Whether it improves these patients or not, we don't know. So I've been asking the industry folks, once it got approved, everyone else is getting it approved, and we still have not seen any prospective data in my mind. So I think there probably is some patients who should benefit, but we got to know who it is, because otherwise we're going to be changing out pulse generators every 2 years in these patients, and Jeannie's going to get to do her follow-up replace registry on all the complications associated with that.
That's such a wonderful talk, thank you. And I'm wondering, you've thought so much about cardiac conduction. How has what we're learning about physiology like this bundle pacing affecting how you're thinking about CRT?
That's a great question. I was just talking to Jean, because I was just at pacing symposium on his bundle pacing, and Rod Tung, who's at the University of Chicago, gave this wonderful talk where they've put a catheter down along the septum on the left side, and they've mapped conduction along the left bundle. And they can actually tell you whether you actually have proximal block, it's truly left bundle, or whether it's just slowed conduction. And as you'd expect in these bad hearts, many of them don't have proximal block, and those patients are probably not going to respond very well to what you do if it's just sort of diffuse conduction in the ventricle, compared to the ones who will respond better if they truly have block within their ventricle. So I think as we get better at mapping, and what's exciting, I didn't have time to talk about, is a number of surface mapping systems are being developed, because it's not practical to start measuring intracardiac left ventricular septum, or even putting leads in and moving them around. If we could stick something on their body surface and know ahead of time what their electrical conduction is, it would make a whole lot more sense in terms of how we can do it. So hopefully that technology, which there are a number of startups working on that, and even big companies have bought some of those startups, will help us to know which of the patients that truly have areas of late conduction and how are you conducting through the left ventricle. Yes.
Micro regurgitation, I told you I was going to ask about. So with the COAP trial coming out of the microclip for patients with heart failure, reduced ejection fraction, and severe MR, the entry criteria is that you have to be on optimal medical therapy and then had CRT if appropriate. About a third of them did have CRT. So I kind of twofold question. How many patients with heart failure, reduced EF, and significant MR actually have an improvement in the MR? What percent improved and how much do they improve? And then in your non-responders, you need to add your list of things to do with the non-responders who have significant MR should we see the microclip.
Yeah, it's a great study. There's actually a paper from Angelo Riccio 4 or 5 years ago in which they looked at mitral clips in patients with CRT who had significant mitral regurgitation, just as you say, and they get significantly better. So I think that clearly is of importance. A majority of patients have some mitral regurgitation. The more severe the heart failure, the more dilated left ventricle as you'd expect, the more severe in general the mitral regurgitation is going to be a proportion of those patients. It certainly appears to be functional MR is the one that's going to benefit. Again, not surprising, because if you can make the ventricle smaller, you're reducing mitral regurgitation for those groups of patients. But I think the data that was known about CRT and the co-op study all sort of fit together, that it should be something, you know, sort of in our toolbox of things we need to be thinking about in terms of treating those patients.
There was a question back there next. Lee, I think you were next.
If you have a lead in what you consider to be an anatomically optimal location, and you're disappointed in the QLV or the LV relationship or timing, you move it?
Yeah. First you yell at the fellow, then you move it.
Works for me.
But yeah, but if I mean, again, I drink the Kool-Aid on this stuff, but if you have a short QLV, you know, you're just not going to respond. I mean, it's pretty clear to me from seeing all this stuff and doing it. We've been doing it for years in our lab and doing it. They just don't do well with it. So you're not in the right place. I really believe physiology trumps anatomy.
Rob, did you have a question?
Yeah, it may be somewhat pedestrian. You told us in one of the early slides the only place to pace that didn't work was the apex, and then you showed us later in your talk that the future of CRT was going to be leadless pacemakers that are all placed in the apex. And so I'm just wondering where some new devices coming out? Is it a different placement? How are you?
Yeah, no, leadless pacemakers can be placed anywhere in the left ventricle. So when they eventually come, so the SOLVE study, it's a screw-in lead. You can place it anywhere in the left ventricle. So the nice thing is that you're not constrained by coronary sinus anatomy. You can go in there, and in fact, the study that we're doing in the SOLVE study, we're truly mapping the QLVs to find where is the latest activation, and that's where you place the lead. Yeah, so yeah, it's a good point though. We're not restricted to the apex.
Yes, back there.
I'm interested in what we might call cardiac desynchronization therapy for hypertrophic myopathy or IHSS. What's going on in that area?
Well, for a while there was talk that you could pace the right ventricle. So Lamy Fernando-Pazier had these papers that forced RV pacing would be good for those patients, and it reduces outflow tract obstruction and other things, and it's sort of been a bit debunked, so it's not been particularly good. Sonny Jackman looked at actually doing left bundle branch block ablation to try to sort of force that sort of stuff, and again, it's not that easy to do, and it never went anywhere. But certainly for hypertrophic cardiomyopathy, I think, you know, what most people would favor is sort of eliminating the obstruction, either surgically or at our place we do a lot of alcohol septal ablations, but to sort of do that. We actually were intrigued by the resynchronization thing because we have a very, very large database of, we're one of the first centers to do the alcohol septal ablation with Bill Spencer many years ago. We're looking at the left bundle versus the non-left bundle to see if we see differences in terms of their remodeling, which we're hoping to actually have finished and submit for HRS abstracts. I actually don't know the data. The reason I was just even thinking about it, I'm glad you brought it up, is one of my fellows texted me about some data stuff he was doing while I was on the plane, so we're trying to get all that together. But it's an interesting question of the hypertrophs. They're sort of fun.
I think we can take one more question before I have to get out of the room. Melissa? Oh, somebody was first? Nazim?
I just had a question about the
We'll take both of yours.
the gender and height interaction.
Yeah.
So has it been looked at just in terms of LV mass? Because CRT really hasn't infiltrated the pediatric world because their QRSs are so narrow. We don't think we can make them better, and it's a mass effect. So is it really height, or is it the LV mass? Can we just get that off the echo?
A good question. The height thing, the mass thing, we don't know yet. So we actually looked at BMI, which is what we started with, and then we had height and we had weight, and it turns out height was the winner, which again was surprising, and someone else has looked at a data set and said they saw the same thing. So,
But I don't think the transplant surgeons would think that's surprising, because that's actually how they, I don't
Right, that's one of your stronger factors for, it's not BMI that you're matching for transplant, it's more about height rate. You match the both, but, yeah, I mean.
This is one of these, again, you stumble onto this thing, and you get some press out of a fun paper, but then, yeah, but hopefully, others will have to look at it. It's nice to talk about.
One last question.
Quickly, do you ever revisit QLV if you have somebody who's a responder, let's say, and their ventricle remodeled in a good way? Do you ever readjust your pacing and change your parameters based on these new findings? Or do you not mess with success?
Well, the QLV will not change based on your parameters because the QLV may change if you remodel, and we actually don't know what happens. QRS durations apparently doesn't change a whole lot because even with responders, the unpaced QRS duration shows relatively small changes compared to what you can get very dramatic changes in remodeling. So the electrical system is a little less plastic than the actual functioning of the ventricle, the mechanical actions of the ventricle. But I don't know. We're starting to look at RV/LV because actually you can do that through the device, whether that timing is being changed from responders versus non-responders. But I don't have a good answer for you, but it's a good question.
Okay, well, I just really want to thank Michael for coming and giving us that great update and review of CRT. Thank you all for being here, and